Talks Live. I am having my very first sponsored show for 2023. Thank you to Integrum for sponsoring this show this evening and for loaning me Kurt Collier. He is the VP of Prosthetics for Integrum, and we are going to be talking about their OPRA implant system. So guys, those of you who are watching the replay, thank you so much. The past few weeks, you guys have been awesome about giving me shout outs that you're watching the replay, posting your questions and comments. So if you are watching the replay, put that into the comments section and go ahead and put your questions in there. I do go back and I check the shows after I've closed them to see if any of the folks watching the replay had any questions or comments. So tonight is a huge show. I've already got some folks popping on board. We've got Harsh on board. Nice to see you. And guys, I am broadcasting to my Facebook and my YouTube channel. Everything is under Kosi Talk, so it's kind of easy to find. And those of you who have been on the show before, you know I love to interact with my audience. So don't be shy. Let me know who you are, where you're from, and what is in your mug this evening. I've got my favorite decaf going on right now. Yep. What you got, Kurt?
A little bit of real caffeine.
The real stuff. Okay.
The real
so you're going to be bouncing off the walls. There we go. There we go. All right. We got Jody coming on board. She is recovering and is at home. Jody, I am so glad to hear that you are doing better and at home after your surgery. We got Dave coming in from Delaware. Dave, thank you so much for the emails. Hopefully this evening we'll be able to answer a lot of the questions that you sent me in that email. We've got Rudy coming in from Albuquerque, New Mexico. We got Patricia here. I am so excited. Oh, a lot of my familiar faces. We got Benny coming in, listening in from Texas. And he's on my YouTube channel. Excellent. All right, guys, we are starting to get a nice crew. I'm going to give you guys another minute or two to jump on board, and then we're going to get the show going. We have a lot of information for tonight. I feel like I've been preparing for this show for quite some time, and I'm so excited to be able to bring this information to you guys. You all had so many questions back in 2021 and 2022 about bone-anchored prosthetic devices and osseointegration, so I'm really excited to have the experts on board tonight. Hey, Rhonda, you got your water from Missouri. Harsh, we will be getting, they're already starting the questions. So Harsh is like, quick question, if this can also be used for below the knee. Yes, it can be used for below the knee, and we're going to explain under what circumstances it's used for below the knee. So we are going to be answering those questions. We got Butch coming in from Minnesota. Are you having some really cold weather? We got Jeannie on board. Oh, Jeannie, thank you for coming on board. I am so glad you're here. We've got Nan coming in from Tennessee. All right, guys, we have got a very nice group, so we're going to officially get this party started. So for those of you joining me for the first time this evening, welcome. My name is Kosi Belloso. I'm a physical therapist, amputee specialist in Tampa, Florida. And with me this evening, I have Kurt Collier, certified prosthetist and VP of Integrum. So Kurt, I'm going to zip it for a minute. I'm going to let you tell folks about yourself.
Yeah, as Kosi said, I'm a certified prosthetist. I've been in the field of prosthetics now for over 30 years, both in patient care and working with different manufacturers, including FlexFoot. I am a little older. Some remember FlexFoot, and then Oser and Freedom Innovations, and did some work with Blatchford. And now I'm here with Integrum, and I have been for the past 6+ years, and it is a pleasure to help introduce this to prosthetists and amputees across the United States and across America. It's my honor to be here tonight.
Well, thank you again. And guys, those of you who think that Kurt might look a little familiar, it's because it's not his first time on the show. So back in November of 2019, right before the United States went and the whole world went, we had Kurt on the show talking about osseointegration and the OPRA, specifically the OPRA implant system, right? And it's just starting to make an appearance in the United States. So fast forward 3 years later, and things have really, really changed since then. And you've really grown since then. So we're going to be talking a lot about that one tonight.
Yeah, we certainly have. I was going to share, we certainly have grown now with I think at the time when we first we did our last show, I think we maybe had 7 centers across the U.S. We're upwards over 30 with 12 of the top 20 hospitals in the U.S. So it's been a real exciting time. Lots of growth.
Lots of growth. Exactly. So we've got Sarah, new transtibial EOPRA patient. Welcome, Sarah. We got Compadre on board. Thank you for joining in. We got Charlie coming in from New York, and we've got Chuck. Oh, we got Susan. So my two of my favorite ladies, we got Susan and Jeannie on board. So we got to be on our A game tonight, Kurt.
Yeah.
Ladies are going to keep us in check. All right, guys. So the purpose of tonight's show is to talk about the Oprah implant system made by Integrum. This is sometimes referred to as osseointegration. And we're going to get a little bit into that too as well, to talk a little bit about the vocabulary, because y'all know I like to get things right. Okay. So as always, guys, whenever I present something on the show, whether it's the shiny new knee or shiny new foot or a new surgical procedure or anything, what I'm presenting to you is a basis of foundation, foundational information. After that, it's on you. You know, I talk a lot about being informed consumers, and that's who you are as amputees, as clinicians, as caregivers, right? We can only present this much in the hour and a half that we do our shows every week. Okay. It's up to you to take the information that you learned tonight and then go out there and do more reading, do more comparisons. This is not the only system available. We're going to talk a little bit about that. And if this is something that you're interested in, if you wonder if you're a candidate in, we're going to provide you with some resources so that you can go and have these conversations with qualified clinicians, okay? With surgeons who have done these procedures, surgeons who can guide you through this process. Kurt here is a wealth of information, and he's been hearing me text him over the past couple of years with questions about this procedure, okay? So let's just go ahead and get started. Let's talk a little bit about, first of all, osseointegration. What does osseointegration mean? Okay, so it's in the word, osseo meaning bone, and then integration meaning coming together, okay? So osseointegration refers to using a metal implant somewhere in the body to interact with bone, which makes the two of them fuse together. Okay. And I really want to make a distinction in this particular word because I think it gets used a little too much and perhaps not in the right context. So we can see osseointegration in total hip replacements, total knee replacements. We see that in dental implants, and we're going to explain that a little bit closer, a little bit more in detail. Okay. So I'm going to show you guys an example. Let me see if I can get this right. Of what osseointegration looks like on a microscopic level. Okay. So Kurt, that picture is going through okay?
Mm-hmm. Yep.
Okay. So guys, first of all, we have a lovely picture of a model here, right here. So you can see what this osseointegration, the Oprah system looks like, right? But I want you to focus on this picture here in the middle where you see the black right here and then kind of purplish looking material. This purplish looking material is actually bone. And this is showing this black part is the metal. So it's showing just how closely that interface becomes between bone and metal. It really fuses together, even on a microscopic level. So you can see that. Hopefully you can appreciate that from this picture. Okay, so let me go back to my screen. Haha, I did it without knocking myself off the internet. So proud of myself. Okay. So guys, that is the basic definition of osseointegration. Okay. So correct me if I'm wrong. A gentleman by the name of Professor Brandemark, right? Back in the 1950s, 60s, help me out.
Yep. No, in the 60s, 50s, 60s.
It was in the 60s.
Yep.
So Professor Brandemark came up with using osseointegration to start creating what we now know as the modern dental implant. So anybody who's had a modern dental implant, right? It's a screw device and then the little tooth gets put in there with it. Okay, so Professor Brandemark kind of was one of the founding fathers of that particular procedure. His son, Dr. Brandemark, okay, a few years later in 1990, used that osseointegration technique that his father had kind of designed, and he gave an above-the-knee amputee woman the very first bone-anchored prosthesis using osseointegration. So hopefully you guys are seeing kind of like the difference in terms there. Osseointegration is the actual procedure technique, okay? Integrating it into an amputee allows them to use what's called a bone-anchored prosthetic device. Am I getting this right so far, Kurt?
Yep, sounds great.
Yeah. Okay, so far so good. All right, let me see who else is coming in. All right, we got Comadre here from Miami Beach. We've got, my favorite occupational therapist on board. We got Andrea there. Susan says, the 2019 show introduced me to the Oprah implant system. A few months later, my life changed forever for the better. Susan, I cannot wait to have you on. Guys, I'm going to brag a little bit. Susan and another lovely lady called Jeannie, they're going to be coming on my show later this year, and their stories are going to blow your mind. Hey, Michelle, thank you for joining. We've got Dulcie here. Charlie says, too small, I need bigger glasses. You know what, Charlie? In my next email I'm going to send out, I'll try to send out that picture because it's a really cool picture to see just how closely that metal integrates with the bone. Kim, glad you could make it. Hey, Phil. Phil, a lot of your questions are going to get answered tonight, so listen closely, okay? So Integrum, so Dr. Brandemark in 1990 did the first osseointegration bone-anchored prosthesis on an above-the-knee woman, right? And then in 1998, Integrum was founded by Dr. Brandemark, okay? And OPRA, and let me just write this down, stands for Osseo-Anchored Prosthesis for Rehabilitation of Amputees. I like OPRA. OPRA is nice and tidy. All right. So guys, as a pause, I'm going to take a pause here for a moment because you know I love my giveaways. I just posted a link there in the comment section, okay? If you haven't already done so, go ahead, right-click, fill out that form that's there, and you'll get entered for a $50 raffle gift card that we're going to announce at the end of the show. So you still have a little bit of time that you can fill out that form, and you can start learning more about Integrum and the OPRA implant system. Even if it's not something that you necessarily might think it's something for you, as an amputee, I think it's just important to kind of stay up to date on all the new procedures and the new technology that's coming out. Yes? Hey, Paul, we got PTs and OTs on board this evening. No pressure for me there, right? All right. So in 2020, okay, and this is the part I kind of want to make sure I say this correctly, Integrum became the first and only company to receive FDA PMA approval for the use of osseointegration as it pertains to above the knee amputees using a bone anchored prosthesis. So as of right now, OPRA Integrum is the only company that has full FDA approval, correct? In the United States.
That's correct. And that's Integrum, the company with the OPRA implant system. So the Integrum was awarded the FDA approval for the OPRA implant system for transfemorals.
And I'm just writing it down. A lot of words we're throwing around there, so I'm just putting that there in the comment section so it's just easy to understand. Integrum is the company. The OPRA implant system is the actual system that's used for that bone-anchored prosthesis, okay? And as of now, in the United States, it is only approved for the use for above-the-knee amputees, correct?
That's correct.
Okay. Hey, Daniel, thank you for joining in. And this is the question I always get from folks, is OPRA the only osseointegration type system available out there for amputees? And the answer is no. There are other systems out there using osseointegration to provide a bone anchored type prosthetic device system for amputees. Okay. For the purposes of tonight's show, we are going to be focusing on the OPRA system. Okay. Hang on, folks. All right. All right, so let's talk a little bit about how this system actually looks like and how does it work, okay? So it all comes together with a three-part modular system, and I think, Kurt, you have the pieces there.
I do. So you see here in this glass bone, the fixture, right, that's implanted into the bone, and that would occur during the first surgery. And then in the second surgery, they will do a lot of plastic work with your muscles and your dermis, your skin. And then they'll place the abutment into the system, and this is your abutment, right? So they'll anchor the abutment into the system, and right, so they'll place it in after the skin is closed, suture your skin and tighten everything down. After a period of time, then you'd start to use the axer, which is the third component of the OPRA system, and this is what's used to attach to your prosthetic device, and includes quick disconnect and connection, as well as safety in two different planes.
Okay. So guys, I'm going to share, it's like a 5-second video, but it just kind of shows very nice and simply how this works. All right. Is that going through? We're good?
It's on.
Okay.
But
so
it's
let
not
me go ahead.
running. There we go.
We're
running. And it's paused. There we are. Yep. So they would anchor the implant into the residual limb, and here then they would attach the prosthesis once it's anchored to the bone. In that regard, here you could see The prosthesis being
It's
applied.
not up. My apologies.
That's okay.
Let me go ahead and actually, I'm going to go back to the original picture that we had because I think it shows the gentleman here, and you can see a nice close up here, guys, where you can see the axer and you can see the little abutment sticking out right there, right from the exit site. Okay, and then you can see it when he's in standing right here. Okay, so as you can see, it basically gets rid of the traditional socket. There is no plastic socket that the person has to wear on their residual limb. One thing I kind of want to call your attention to is how clean this exit site looks. And we're going to talk a little bit about that in just a moment. Okay, so here, let me just go ahead. Woohoo. Okay, so Adam says, any plans to have it pushed for below the knee? So you want to take this question, Kurt?
Sure. Yes. No. Integrum is a very scientific-based company. So, we started with the transfemoral level because we had the most number of points of data, the most individuals that received it, that we could collect that information and then provide to the FDA. We haven't done as many with the transtibial level, so we're still trying to collect all that information. But yes, the intent is to pursue an approval in some time with the FDA for the transtibial level. Yes.
Okay. And then folks, just so you know, understand, sometimes because people are like, well, I've seen some people in the United States walking around with the transtibial osseointegration. So what's the deal there?
Mm-hmm. Sure. So as we said, the transfemoral level is FDA approved, and that's because it's approved by the government, it's no longer deemed scientific, and it's approved by our healthcare system by them giving that approval in that capacity. And so movement to the procedure is relatively seamless because it's an approved product. If you want to have a procedure done, such as the transtibial level, that would require a compassionate use filing, meaning there's nothing on the market like that product for that individual, the transtibial amputee. So that manufacturer of that implant would make an appeal with the support of the surgeon. What's the surgeon that's really making the appeal to the FDA in conjunction with the manufacturer, saying, I would like to use this device. There's nothing else out there for that patient like this. And we would, under compassion, we would like to be granted the use of this device. And that's what occurs, and the government would grant that device for that use of that implant. So it's typically a case-by-case approval for those individuals.
Absolutely. So let's talk a little bit about how the Oprah implant system is a little bit different from other devices out there that are being used for osseointegration for amputees. Obviously, the three-part design, that's the first thing that stands out. And a little bit of the engineering behind that three-part design is to help prevent and protect the femur from being fractured during these loads, correct?
That's correct. The implant system developed by Dr. Brannemark, little known, Dr. Brannemark was an engineer before he became a physician. So he's built the system redundant for safety. So if we just look at the system alone, right? So just the implant alone has mechanisms to keep the bone healthy. So if somebody happens to have a very, very high load, right, we first have the safety built into the axer device. So during rotation, the system would release itself and could be reset by the amputee for a high rotation load, right? Because we want to keep the bone healthy. So that would be absorbed here in the axer. If somebody fell and had a flexion moment, right, beyond what the knee bends, this system will release like ski boots in a ski binding. There's an axis here. It would pivot and release at a high hyperflexion force. Mm-hmm. Each instance, it can be reset by the amputee. So your first line of defense for safety is built into the axer system itself. Then built into the implant system is if the load is high, right, we have a screw that could be bent, right, and the abutment that could be bent, all before the force is transferred into the bone. These are made modular, right? So if there is bending, right, if a high moment does occur that's not absorbed by the axer, right, and some damage, this system can experience that bend. It can be repaired. right? So this has been a design system to be modular for several reasons, right? So this abutment can be replaced relatively easily in a 20-minute procedure as an outpatient procedure if needed. It's rare, right? But again, the system is built with redundant protection for the benefit of the amputee.
Which is hugely important. So Charlie, yes, they do have it in Australia, but it is not the Oprah Integrum system. It's a different system, a different type of osseointegration device that they use. Rupert is asking, how does it feel compared to the conventional socket? And Jeannie was so kind to reply. She says, much better control, better proprioception, greater range of motion. It's pretty great. So guys, think about it, right? You don't have a clumsy socket on, right? So any kind of limitations with your range of motion, gone, right? And if you look at, hang on, of course, all of my sockets are gone because I think my kids were playing with the sockets. But if you look at your socket, right, you're limited, your muscles are encased in there. So the ability to contract fully is going to be more limited versus it being open to air, right? And
Yeah,
then as far
Kosi, I was going to say it's amazing when you talk to these individuals that have had the procedure done, they'll talk about suspension. And they talk about it in the perspective of freedom because everybody knows where their leg will suspend and not break the seal, right? You know that safe zone is. And now all of a sudden, like you can go beyond that without thinking about it, without apprehension or fear, and which soon develops into confidence, which is really neat to see.
let me see, guys, be patient with me for just a moment because I want to show you. It's again just a few seconds of a video clip. And I believe it's this one. Hopefully I got it right. Huh. And it shows a gentleman putting it on. So I just want you to see, let me see, make sure I get it right. Aha, I got it right. Okay. Okay. There is lots more to that video, but I'm just gonna have to stop it because if not, we'll keep watching that video. But a couple of things I want you to notice, guys, is how quickly did he don his prosthesis? Like 20 seconds, right? How long does it take some of you sometimes to don your prosthetic device? And then sometimes, especially those of you who have like the liners and everything, and you put everything on, you stand up in it and you realize, my liner's rotated. So you have to sit down, take everything off and re-don everything, okay? So there's a lot of things here in terms of advantage. Sitting down, that's another thing I've heard of, is when folks sit down, they're not sitting down on a hard plastic. They're sitting down on their thigh muscle, the way that they were intended to sit down. Susan has a great question. What protects the skin around the screw?
That is a very good question. And so that lends itself to the two-stage procedure that's so unique to the Oprah system. So in the second procedure, we create the opportunity for the dermis to be anchored to the end of the bone through adherent scar tissue. So scar tissue will form and that'll anchor the dermis to the end of the bone, and that's going to stabilize that. That dermis is actually, capillaries are going to grow from the periosteum, like a skin on the bone, and vascularize that dermis. So it's very healthy site. So it's not necessarily protected. Now, some people, the piece of titanium that sticks out, right, when people don't have their prosthesis on, they might put a protector on the end of that system just when they're sitting around the house, right, because they don't want to hit their furniture or something like that.
Snagged or anything.
Yep. But as far as around where the skin is anchored, nothing is placed there. It's a dry site in most situations.
And if you guys could see from the video, it's very, I like to call it clean and tidy and aesthetically pleasing. So let's talk a little bit. Oh my gosh, these questions are rolling in, guys. I do not want to miss your questions, which by the way, guys, if I miss your question or I don't get to it, keep posting it in the comment section. Don't be shy about that. David, we're going to talk a little bit about the age. He wants to know, what is the age of your oldest patient? And what about folks who have very long residual limbs? Good question.
Those are good questions. We'll start with age. So, in the study that was done and submitted to the FDA, it was ages 22 to 65 in the age range. But that's the subjects that were in the study. The surgeons are going to make the determination as to whether you're a candidate. And each surgeon makes that decision themselves upon their evaluation of you, right? So you would make an appointment just like you would go see another doctor. There are certain doctors that we have, that use the system. You'd go see that doctor, be evaluated, and they would make the determination if your age, if you were healthy. Really, like, we've all heard he's a really young 70-year-old, right? Well, there's a lot of truth to that.
Yeah.
As far as length, right? There's a protocol that all the surgeons are well versed on, and we're actually present in the first several surgeries with the surgeon, is helping them make sure they're up to speed. And then we're always present with surgical technicians as well from the company at all the surgeons. But with that said, in that protocol, right, we know we have to fit this axer in. So there's always going to be, compared to your sound side knee, right, they're always going to have at least 14 to 17 centimeters removed to make sure this fits in. It's typically 17, right, is the thing, but in case there is a range, but it's standard 17 in that regard. So that would always be accommodated for. They're not going to create a leg length discrepancy by providing the implant for you.
There you go. Charlie asked, when my foot was fussed, my body rejected the hardware, fused. I'm sorry. Boy, I can't read this evening. I was constantly getting infections until it was removed. Would this work for me?
Again, I'm a prosthetist, so not a
Yeah.
physician, and I don't want to be, so I won't claim. But again, it's a great question. It's a question that each physician, we work specifically with some of the best orthopedic oncologists across the U.S. And we work with that type of physician because they have such a better understanding of bone, and not just an orthopedic surgeon, but an orthopedic oncologist. In most cases, not 100% of the time, but in most cases, the surgeons that we're working with, and that's because they have that understanding, they have that diverse knowledge of the bone interaction in good scenarios and in bad scenarios.
So, and then the last question, then we're going to keep going. Phil asks, is Integrum available in Canada?
At this time, we haven't distributed the product into Canada yet.
Okay.
Lots of talk, but we're not there yet.
Okay. So let's go ahead. And actually, before I get started with this next part, we're going to start with our another giveaway that we've got going on right now. Sorry. Y'all know I'm a little slow with the copy and pasting, but I'm going to get it. All right, guys. This giveaway is for a $25 gift card. Got your attention? All right. So I just posted the link to the Integrum Facebook page. Okay. So listen up. This is what you got to do. You got to follow them, and then you got to like the post that they just posted today. Trust me, you'll know which one I'm talking about when you see it. Okay. So go ahead and do that. And then some of our folks from Integrum are going to pick a winner from there and give you a $25 gift card. Okay. So guys, we're going to get to some of these questions I'm seeing here. We're going to be getting to them. I love it when we get these many questions. So let's talk a little bit about how the whole process works. So the very first part of it is the screening process, right? And there are several of you that I'm seeing here on the show that in the past, you have asked me about OI and about Integrum and about Oprah, and I sent you directly to the source to fill out that patient form that some of you already filled out, right? And that's the first part, is just getting in touch with the right people to do the screening, right? So when someone contacts Integrum, they are put through a screening process. And do you put them in touch with a surgeon, or do typically they find a surgeon in their area that you've recommended?
So we're going to, and if a patient reaches out to us, we're simply going to ask them, where are they looking for their care? Would they be are they want to go in town where the surgeon happens to be? Do they have family members somewhere else? As I said, and then we just give them that contact information, and that patient will reach out to that surgeon, and that surgeon will do his screening process for that patient, because it's his case. That patient is his responsibility.
Right. And among some of the things that the surgeon may be screening you for will be, obviously your overall health. What is your medical history? What is it that makes you feel that you are a candidate for osseointegration or for the OPRA implant procedure? Okay. What is it that you are hoping will change, right? In having this procedure done? Okay. Your ability to, be a good surgical candidate. All of these things get factored into the screening process. So after that, right, if you are approved for this process and you're deemed to be a good candidate, you have what's called the stage 1 surgery. And this is where you have the surgeon goes in, opens up the end of your residual limb, and they put the metal fixture in the medullary canal. So basically, how when you're eating a chicken wing or sorry, chicken bone, right? And on the inside, when you open it, you see the bone marrow. That's exactly where that little screw is going to be implanted at that point. And then the skin is closed over it. Okay. So this is a little bit different from other osseointegration procedures that you might see on other OTs that are not with OPRA. So can you hold up the part that gets inserted again, Kurt? Okay. So it gets inserted in. And then the surgeon closes the soft tissue over it. So there's no opening at this point.
Correct.
Okay.
Yep.
Correct.
So
And
they're
then
just going to
go
let
ahead.
the system heal in place, right? And some of this bone harden down here as well in that procedure.
Okay. And then after that, you spend it's the healing phase. So depending on the individual, it may take anywhere from 3 to 6 months for all of these tissues and for the bone to integrate into the metal implant, right? It used to be, and at this time, and so correct me if I'm wrong, the first 5 to 7 days, the person is on bed rest in the hospital. And then after that, they're up mobilizing. And then after 6 weeks, if they're cleared by their surgeon, they can actually start using their traditional socket again, correct?
They can go back to a traditional socket once the sutures are removed from that limb. So in that situation, you're more than likely you're going to have a socket made for you because there's still hardware in the bottom of that bone, right? So there's a little cap here, and we don't want an individual to load in the socket through the distal end of the bone because that could shift that cap. And that might distort this little hole that we're opening here. But aside, if a prosthetist is careful and they know how to, they make the proper socket, you could certainly go to a socket in between stage 1 and stage 2.
Okay, so just to recap, you get through the screening process. Stage 1, they insert the fixture, close everything up. Healing phase 1, you're up, you're moving around 3 to 6 months, waiting for that bone to really latch onto that metal implant right there. Okay. Stage 2 surgery. Okay. This is where the surgeon creates that opening. And I used to call it a stoma, and I don't call it a stoma anymore. The reason is because this is not a stoma, right? Stomas are basically, it's open. You see the tissue from the inside opening out. Like when you see somebody with a colostomy, right? That you can see inside and you see that tissue. With the particular openings that are created with the OPRA system, it is so closed tightly with the way that Kurt explained about how all of that tissue is integrated into the bone. And it's just really nice and tight in there. Okay. So that's what happens with stage 2. Okay. So with the stage 2, the opening is created and the abutment is attached to the fixture.
Yes. They're also going to, at that stage 2 surgery, the plastic surgeons are also going to come in and attach your muscles to your bone as well, so that the muscles will move the bone when they contract as Mother Nature intended.
There we go. Okay. And then after that, that's where the real fun begins for people like me, the PTs, right? So we're in the healing phase part 2. Okay. So about 3 weeks after stage 2 surgery, and again, guys, everyone's going to be a little bit different depending on how they're healing. Okay. The person is allowed to start partial weight bearing, and they call it a shorty prosthesis. And it kind of looks like a stubby prosthesis, right? So they'll start, and we're going to get more into this. By the way, guys, we have a show in May 3rd. We're talking all about the rehab side. So I'm just going to briefly touch upon it because I'm going to have an expert coming in May to talk about the rehab side of things. Okay. But during this, you start loading that residual limb little bit at a time. Okay. And after about 9 to 12 weeks, did I get that right?
Mm-hmm.
The patient can start using the full length prosthesis with the axer attachment that he showed you.
Mm-hmm.
Okay.
Yes.
And that's all
Yes.
I'm going to say, because if not, I'll start talking all about the rehab side of it. And that's a whole nother show, right?
Yeah. Now it's a fun rehab from the perspective of, you're not just loading without your soft tissue, right? You're not loading through your soft tissue. You're loading through your bone. People will say they don't even feel it. They don't feel when they stand on it. The rehab, right? We're working all those muscles, right? Because all those muscles got reattached. So yeah, even if those muscles are atrophied, we can get them back. But I'll let Kosi share all that with you in another show. But it's a programmed rehab, right? So you want to follow the rehab, and that's why it looks like it takes so long. You're making progress, but the program is structured for a while so that you get the full benefit of the rehab.
Yeah, absolutely. And we've got some questions. So I'm going to start answering some of these questions. Susan's asking, how many surgeons actually do the procedure? So, Susan, as of right now in the United States, the Oprah system is being done in about 35 hospitals, I think was the last count,
Mm-hmm.
right? And then you mentioned that 12
12 of
are
the
in the
top
top
20
20.
hospitals, yes, across the US are using it.
That says something right there, guys. That says something right there. Andrea says, Integrum is presenting at our support group in 2 weeks. Very excited. Oh, yeah, it's going to be fun. Lori asked, I have a short femur, 5 inches with several inches of adipose tissue. Would they need to remove the extra muscle to use the implant?
So that's a great question. We can place the implant essentially in 10 centimeters of bone, right? So that's 2.5, basically 2.5 inches
Wow.
from the greater trochanter, right? So that's a very short femur. That's
Very
about
short.
a 2-inch femur. As far as the soft tissue, right? They're going to work with the muscles, and so they may remove some of the soft tissue. They may leave it there, but that's where the plastic surgeons. We work with an orthopedic oncologist on one side of the surgery, right? And then we work with a plastic surgeon typically on the other side of this for the stage 2 surgery. And so
Yes.
those teams, right? They're going to make the best envelope, right, for you to use this implant. Is how basically how it evolves.
Absolutely. And then I was just thinking of this, a couple of times when I'm following some folks online who've had this procedure done, some of their surgeons opted to be a little more conservative and
Mm-hmm.
keep the soft tissue, right? And because
Mm-hmm.
obviously once you take away soft tissue, you can't put it back. So they kept the soft tissue there just to see how it would progress. And sometimes they needed a revision with the
Mm-hmm.
soft tissue, which is a much more simple procedure. And sometimes not. Okay. And again, this is where the skill of the surgeon is really so important, to ask these questions to your surgeon, especially if you are someone who is prone to having a lot of extra tissue on your residual limb. So David, yes, the person who makes your socket after this would be your prosthetist. Yes. And again, skillful prosthetist, right? Making sure that there's no weight bearing on the end of that residual limb. Susan, good question. What happens if your muscles have atrophied? That's where you come see me. Right? So that's our bread and butter. Okay. For me, if there's even a twitch of a muscle contraction there, we have something to work with. Okay. We have something to work with. And it's a matter of putting in the steps and doing the protocols and getting that muscle strengthened. If anything, when I think to myself of like, wow, whenever I have a patient who comes in with a fresh prosthesis, I spend so much of my time educating that person on skincare, volume, sock management, how to don and doff. And I'm just thinking, how much time would I be dedicating to strengthening and starting that gait training right away, with someone with osseointegration? So for me as a therapist, I'm like, wow, I'm going to have more time to work on that side of it. Okay. And y'all have heard me say this a bunch of times: use it or lose it. Muscle strengthening, it's a part of your life forever, whether you have 1, 2, 3, 4 legs, however many legs you got. Muscle strengthening is something that you have to incorporate into your life as you age. Okay. Hey, Keith, what's going on? Let's see. Jeannie says, I didn't walk for about 3 years prior to getting the Oprah system, so I had a lot of atrophy. My rehab was a bit slower, but muscles are coming back and I'm able to walk without any assistive devices now. Jeannie, I hope you don't mind if I put you on the spot a little bit. Would you mind putting your Instagram handle? Because folks, if there's anybody to watch, is this amazing young woman, both Jeannie and Susan. If you don't mind putting your Instagram handles on here so folks can see just how amazing you are, that'd be lovely. Ah, thank you, Thomas. Let's see. Jeannie said, I just had a soft tissue revision last week and it was the easiest of all my surgeries. Susan, good question. Can muscle strengthen just from walking, or am I simply swinging my leg forward with my hip? It's a two-part thing, Susan. In order for you to walk and walk properly without gait deviations that can later cause chronic problems, you need to do some pre-gait strengthening. Yes. By the same token, as you walk, you are strengthening those muscles. Okay. So, again, this is where the physical therapist comes hand in hand with the prosthetist and the surgeon. Okay. Because, yes, we want you walking because that's going to strengthen you. But to make sure you're not compensating, okay, we got to make sure those muscles are strengthened on their own as well.
Yeah, Kosi, you made a really good point there talking about the team. And, one of the neat things about Integrum is they really, I have identified, because they provided the surgery in Europe for many years prior to bringing it here, and they identified the significance of the team. So, as you said, right, we invest in training and educating the surgeons and making sure they're right at the top of the food chain. They've got to be able to put the implant in there properly. Right, we need the prosthetist to build the temporary prosthesis and the permanent prosthesis well and align it, but we need the therapist to provide the therapy appropriately. And so the company has invested, and it's a significant investment to make sure that all of those parties are trained and educated on the system so that they can work together and give us the best outcomes. And again, that's with all the centers, right? That's multiple prosthetists for each hospital. It's multiple therapists. But again, it's really the way the company sees the significance of that and the importance of that for the best interest of the patients and their outcomes.
Absolutely. Glenn says, thanks to Kurt and Kosi back in 2019, I was able to get an appointment at Johns Hopkins, had my first surgery in December of 2019. Thank you for sharing that, Glenn. So David asked, total time on average from start to walking strong. So if we did the math.
Yeah, no, I think it's 9 to 12 months is a fair number to share. I can also say that, as any amputee that's gone through the loss of their limb, right, there's that 18 to 24-month window, right, where you really have fully understood it, embraced it, the ins and the outs. So yeah, you're up and walking and ambulating in 9 to 12 months, like strong, got it dialed in, know it backwards and forwards, right? I think there's a little more time there in all fairness, but I don't think it's any different than what any of us have experienced as amputees from a traumatic loss.
There you go. Bobby asks, is it truly osteo if it's screw fixated? So
yeah, no, that's a great question.
Answer, but I'm going to see what you say.
And that's a greif the image that you had that showed, the contact between the bone and the titanium, if you were to take that to a microscope, and you could actually see the osteoblast actually embracing the titanium. They reach out like arms. It's a little spooky, but they actually do grab a hold of that titanium, and that does anchor it in that regard. It's embraced by the bone.
So guys, in my email, if you haven't already signed up for my email subscription, and no, this isn't actually a shameless plug. This is just because I'm going to send out some really cool pictures and you might want to see it. Go sign up on my CosiTalks.com. If you scroll to the bottom of the main page, you can sign up for my email subscription. I'm going to find these pictures and I'm going to put them into the email that I'll send out this week so you guys can see what it looks like, because I think it looks really cool on a microscopic level. So let's see. Aha. Oh, actually, I'm so sorry. But we've been talking so much, I forgot to announce our winner for Facebook. So Rhonda. See, there's good conversation going. That's why. So Rhonda, you are the winner for our Facebook page giveaway. And I'm actually going to go ahead and post for the next giveaway. All right, folks, I'm going to give you guys a little bit longer on this one. So I want you guys to sign up on this one. So right there, I just posted the Instagram handle for Integrum. Okay. So those of you who are on Instagram, pop over there, follow Integrum, and then like the post. Once again, you're going to know which post I'm talking about, okay? And then our Integrum folks are going to randomly pick a winner for another $25 gift card. Okay, so let's talk about who is the Oprah implant system candidate? So globally, right? Globally, the procedures being used for transhumeral, transradial, above the knee, below the knee, finger, and even thumb amputees, right? In
Yes.
the US, as we've mentioned already, it's only been approved for the above the knee amputee. So what is the criteria? Let's talk a little bit about the criteria, right?
Mhm.
So number one, it's a person who has experienced an amputation due to trauma or cancer, and they've had problems with the rehabilitation process that they cannot use a traditional or conventional socket, or that they anticipate having problems
Mhm.
using a traditional socket. Okay. So it doesn't mean that you have to try using a socket first and then you become a candidate. If you meet some of the criteria prior to getting your very first socket, you can already be screened for this procedure. Okay.
Mhm.
So what are some of the things that off the bat are going to make you probably a little bit more complicated in using a traditional socket? Skin. Okay. Those of you who have grafting on your residual limb, right? Those grafts can be extremely sensitive to sockets and can create a lot of problems with blistering and open wounds and shearing and friction. Okay. Short residual limbs, right?
Mhm.
Those of you who have very short residual limbs know that it can be quite the challenge when it comes to suspension, right? Getting good suspension, getting that socket to stay on properly. Okay. What am I missing, Kurt?
Well, the envelope invaginations, right, where we know the invaginated scars,
Yes.
right, are another patient population that have a hard time with sockets. We've seen some individuals that have hyperhidrosis, right? People that have a hard time with sweating, and
Yes.
just all that moisture. This is going to be able to address that. And another
Mhm.
individual another population that we talk about is bilaterals. With the ease and the control, the ease of donning and doffing, the control of the system, the repetition of alignment, right? It's on the same way every time. We see a lot of success with those individuals as well. And there's the third, there's another large, a group of people that have with the short femurs that have a lot of mass in that socket because, right, it's the bone has to compress that tissue against the socket wall that's going to move your prosthetic components, right? And if you have a lot of mass, right, there's a lot of compression that might go on before your socket moves, which moves your prosthesis. But if you're directly anchored to the bone, the moment your bone moves, right, now you're activating all your prosthetic devices. So
There you
those
go.
are some other populations where we've seen it apply.
Okay. Folks who have pain using the traditional socket and they've been going at it over and over and over, and they simply cannot find a solution, a pain free solution
Mm-hmm.
to using a conventional socket. Right now, the recommended age range is ages 22 to 65, but there's a big old asterisk, right there with those age ranges. Because as Kurt mentioned, sometimes you have folks that are older than 65 that are much younger, than what their biological age would dictate. Or if somebody who's perhaps a little bit younger than 22, it's actually 25 is when your growth plates completely in every part of your body are completely fused. But you might have somebody who's a little bit younger, but already skeletally mature. And that's something that can be determined very easily with an x ray. Again, these are all things that your surgeon makes that final call and makes the decision when they're doing the screening process. The other part, and I know some folks ask about this, is the weight. So they recommend folks who are under 220 pounds. But again, asterisk, asterisk, asterisk. If you're
Mm-hmm.
looking at somebody, I imagine, who's a very, very tall individual, so 220 pounds looks much differently on that individual than it would on someone who's shorter.
Mm-hmm.
Is there
Exactly.
any other asterisks that I should be including here?
No, I think that's a great summary. And again, it's the surgeon's determination, right? So they're going to be the ultimate screen.
Yeah. Yep.
So you don't have to screen
Absolutely.
yourself. Is what I'm saying. Let them
Right.
say no.
Right. And these are questions to ask yourself. Okay. So now let's talk a little bit about who is not a candidate, right? Because we all like when we have a nice new hammer, everything looks like a nail, right? So we want to make sure we're asking the right questions. So the people who are perhaps not a candidate for this procedure, someone who has severe peripheral vascular disease or poorly controlled diabetes. Okay. And guys, the reason for this is because with this surgery, as with any kind of a surgical procedure, you need good circulation. You need good circulation to get good healing, both for the bone and the skin, right? So, those of you who have the poorly controlled diabetes or severe peripheral vascular disease, you can see where this might present a problem. Okay. Then we have patients who are not done growing, which we mentioned that before. So somebody whose growth plates have not completely fused yet. Pregnant women, someone who has osteoporosis with the weakening of the bone. Obviously, you need good, strong bone stock there to be able to continue and support the metal implant. And individuals interested in high impact activity. Asterisk, asterisk, asterisk. Okay. So, guys, when I was first learning about osseointegration, because I'm a runner, I love treating runners. So, the first thing I told Kurt is, well, what about my runners? Because, so I'm going to let Kurt explain this a little bit more about folks who are interested in high impact activities.
It's a great question. An individual has had this implant placed in their residual limb, and it's a very involved process, and it's taken a lot of time. And high impact forces can put this fixture at risk in the bone itself. So you really don't want to expose the implant to high impact loads. There is an ability to create a socket where you create a socket over top of the implant. It's a traditional socket, right? So you're not going to suspend from the abutment. You're not going to load the abutment. You're going to create a silicone envelope that incorporates the space for the abutment, and then you would get fit with your traditional socket that was ischial load bearing that you left for your high impact sports. The other thing to consider is the procedure's not going anywhere. Right. So if you want to slay those dragons and take on your marathon and get a triathlon in, and then, you get to my age, you say, all right, I'm out. I don't need to do that anymore. It's still here. And so I put that out there too for people to think about.
Okay. And then, guys, as you could see from that, the few seconds I was able to show you on the video, you see the gentleman there walking on the beach, which, living in Florida, I get that a lot from my patients is, how can I get back to walking on sand? How can I get back to walking on beach and hiking and things like that? So you have a wide range of activity available to you with this. Okay. So let's talk a little bit about the pros and cons. I think there was a question here about talking about what are the cons. And guys, I always like to be very upfront and open about this, because this is a very big commitment, very big decision to make. And you need to go into it with as many facts as possible, right? So the benefits, we've talked about eliminating socket related problems because you're eliminating the need for a socket, right? Greater comfort for sitting down when you're an above the knee amputee. Improved sense of proprioception. Y'all know that's my favorite word to use on this show, right? Proprioception, the ability for your body to know where it is in space. So the quick test is close your eyes, give me a thumbs up, right? You know how to give me a thumbs up because your brain knows how to send those signals, right? When you have a prosthetic foot, knowing where that foot is in space every time you hit the ground with it. Okay. So because this metal implant is going into the middle of your bone, that's feeding all of those all that proprioceptive input is just going right there to the source. You guys saw from the video, it's easy to take on and off. It's 20 seconds. It's just pop it on, tighten up that screw, and off you go, right? Increased range of motion, right? Because you're not limited with that socket. You're going to have full range of motion available to your hip. Improved bone density. And this is kind of a big one for me. I love seeing that you will have better bone density. As many of you know, as an amputee, over the course of time, you actually lose bone density, because with a traditional socket, you are not supposed to be putting weight into the bone with a traditional socket. Right. And it's a use it or lose it scenario. So if you're not putting any pressure into that bone, you will lose bone density. So with Oprah system and osseointegration, right, we're starting to see on x-rays that they have improved bone density, just an x-ray alone. And then the skin opening, I like it in the Oprah system because it's just, like I said, it looks prettier overall, and you're able to go in and out of water. Okay, so that's another thing. You can go, your patients can go swimming at the beach, pool, right?
Yep.
Yeah.
Yep.
Thumbs up on
They
that
can swim in, take showers, right? Showers, the whole 9 yards. So yeah, you're open. Your own backyard jacuzzi, right? To stay away from, I say, stay away from gyms, right? And their hot tubs and the
Yeah.
like. Be smart.
Yeah. Yeah. So things to consider, right? So these are things to consider. The risk for infection. Is there a risk for infection? And the answer is yes. And I'm going to let Kurt
Mhm.
talk a little bit more about that.
There is a risk for infection. So, there are people that say, is this for everybody? And if you're happy with your socket and everything is going good, you have to understand that there's a risk involved to receive this implant. And so we talk about for the OPRA system, we talk about two different types of infections, right? One is a deep bone infection, right? And that's with the fixture, and that's not a good one, right? That one will occur sometime in the first year typically. That infection occurs 8% of the time, right? That and of that, that's deemed that they can correct it half of the time and save the implant, right? It's a modular system, so they can remove the abutment if they need to. They can put you on intravenous antibiotics. They can remove the abutment, flush out the system, antiseptic beads to get ahead of the infection, and that's corrected half of the time. So that means of that 8%, right, 4% are going to have the fixture removed. And there's a strategy how to do that. We don't have to go through it, but you remove the fixture because this is round with a round trephine drill bit that can go around the outside of the fixture, and you don't lose bone length, right? So you could go back to a socket. Now that's that's half of the 8%. Of the 92% that are successful, right, moving down the line, you can expect a topical skin infection once every 2 years. It's like a cold, right? You'll take a course of oral antibiotics to address that topical skin infection, right? And that will address that topical skin infection. In 85% of the time, you continue to wear your prosthesis while you fight that topical skin infection. Now, we've carried this out in a study that was recently published out for 10 years, right? So we've seen this dermal infection rate, right, over that period of time. And that's about where it stayed true to that case. So those are the numbers, right, that I think everybody should be able to quote if you're going to move forward with this. And you should have it accurate. You just know it, right? Because it's what you're accepting.
Okay. And guys, I want to add a little bit more onto that because people are concerned about the infection. They hear infection and they go, ah, right? So as Kurt mentioned there, and I actually have the study here where it showed of the 8% that got a deep bone infection, right? So that's a very small percentage. When it comes to the other 92%, here's what I want you to think about. If you're someone who struggles with skin issues, right? You're constantly blistering, you're having the invagination causing problems, you're having open wounds, right, on your skin system. How often are you having to address those skin issues? How often are you getting skin infections? How often are you having to go back to your prosthetist to get your socket adjusted to try to accommodate for those skin issues, right? So once every 2 years, which what Kurt mentioned, it's about the rate that the average human being gets the cold, right? That's about what you can expect. Okay. Which is, and again, oral course of topical, that's not correct. Quick oral course of antibiotic and it's cleared up. Okay. But definitely things to ask, and especially those of you who do have a previous history of infection. So there was another gentleman here who had mentioned about having infected hardware in a different procedure from an ankle fusion. This is definitely something that would need to be taken into consideration, right? Somebody's already prone to having, for example, MRSA, right? We all know MRSA kind of tends to lurk around. Then yes, that's something that you have to have a very serious discussion with your surgeon to see if you are a candidate or not. Let's see, there was another question here. Very good one, actually. Andrea asks, what about former transplant recipients? So folks who have had an organ transplant, which means that they're on heavy immunosuppression.
That's a good question. I haven't been asked that before. Again, that's going to be a default back to the surgeon that's going to be in charge of your case. They're gonna complete a thorough evaluation, and that would come out in the evaluation, right? And so they would identify that. From that regard, as far as implantation, right? Whether you have hardware that needs to be removed and be implanted, that can be done and has been done. Essentially, and if you're congenital and you've never had a limb and you're worried about that, what we're going to need is 2 millimeters of cortical bone, and that's the hard bone on the outside. Is what they'll look for in that regard.
Okay. So let's see. Hang on. Oh my gosh, I lost my place. That's no good. Nope, I got it. All right. So there always is another. So we talked a little bit about the risk of an infection. There's the risk of bone fracture, right? Because of the fact that you have a metal implant that's implanted in the femur. And we talked earlier in the show about how the three-part structure of how this whole structure is made is to help prevent that from happening. But that being said, always a risk, right? Anybody who falls down is at a risk for fracturing their femur. So that's always something you want to take into consideration. There's always a risk of loosening of hardware. Okay. So those of you who've had total hip replacements, total knee replacements, some of these caveats might be sounding familiar, right? These are the risk factors that you have to take into consideration when you're having any kind of a metal implant placed in, that there is a risk for the hardware loosening. Okay. And then we already talked about the inability to perform high impact activities, but we already talked a little bit about that with the asterisk there. Okay. Let me scroll through. Okay. Like these questions are coming in amazingly, guys. And by the way, those of you who jumped in a little bit later, if I missed your question, please feel free to put it in the comments section again. And you can also email me directly. I'm going to put my email there. Okay. If I missed your question, don't be shy. Send me an email and I will get you an answer back right away with that. Okay. So let's talk about, oh, we have another email winner that came in. My phone is blowing up. I love it. Okay. Okay, so our Instagram winner is Marianne. Marianne, congratulations. We will be sending you out your $25 gift card. And in a few minutes, guys, I'll announce who our big website winner is at the $50 gift card, right? So before we get to that part, I just want to kind of go over like my thoughts on Oprah, because some people are just like, well, Kosi, why did you choose Oprah? Why didn't you decide to talk about some of the other devices? Okay. So number one, first and foremost, it's the one that's FDA approved here in the United States. Plain and simple, right there. Okay. You don't have to leave the United States at great cost, at great expense, and a great expense of your time as well to travel overseas. Okay. Here we have incredibly well qualified surgeons in amazing hospitals that are performing this procedure with great success. Okay. Number two, comprehensive treatment program. Okay. Here in the United States, and I cannot speak for outside of the United States, here in the United States, if you are an Oprah candidate, you are receiving the comprehensive system. Okay, so what does that mean? It means you're being screened by a surgeon who has been trained and trained and trained in this procedure. Okay, you're also receiving the PT and the OT and the rehabilitative services around it. Okay, there are some very, very well thought out protocols started by Walter Reed Hospital, right? The big military hospital right there. And they started these protocols. I have it sitting in a folder right over there. It's like all nice protected there because I love that protocol. Okay. So having the physical therapist and occupational therapist who is trained in this, that is going to be a part of your recovery process. Okay. And I will be the first one to say, you will not have a successful outcome unless you have the PT and OT doing the rehab process. That's it. No ifs, ands, or buts on that one. Okay. And I would say that for any amputee, right? Any amputee should be receiving PT and OT services, but especially so if you've had any form of osseointegration procedure. Okay. And that's not always the case with other systems that are out there. Okay. The three-part design, I like that. I like the way the engineering is done. That's just me, my personal preference right there. I like the fact that it's built specifically with these safety protocols to help prevent rotation, to help prevent the fracture from happening. Huge, because I have seen fractures in other cases with other systems. Okay. So to see that that's been built in, I like that. Okay. I like the skin exit treatment. Okay. I will not lie, guys. The very first time I saw an osseointegration, it was not an Oprah patient. It was a different patient, global international patient. And the wound was weepy. It was open. It was draining. Okay. And I used to do wound care for years. So that just like made me go berserk. And the prosthetist said, no, that's how it's supposed to look. And I said, oh, dear heavens, why would anybody do this? Okay. And then I met Kurt and he said, nope, that's not how ours look. Okay. Okay. So that for me is a huge selling point right there, is just, you want it to look good, right? You don't want it to look weepy and draining and have people go, is that okay? Is that the way it's supposed to look? Right. So those are just my personal preferences, take it how you will. All right. So let's talk a little bit about, wrap it up, and we're going to talk a little bit about where you can go for more information. Okay. So I'm going to post, oh, good heavens, guys, their website is full of information. So I'm just going to post the website here. Okay. But if you just put in Integrum, you'll see it up in Google and it'll come right up there on the Google search right there. Okay. So lots of information here. There's a form that you can fill out if this is something that you're interested in and you want to learn more information about. Okay. But let's talk a little bit about how you should be screening your surgeon. Okay. So let's say you go make that appointment with the surgeon. Some of the questions you should be asking them. Okay. So here's some of the questions that I put together, and I know Kurt will jump in and help me out here. How many procedures have you performed? Now, granted, here in the United States, it's been here for a few years, so it's just starting to get around. So you're not going to have a surgeon who said, well, I've done 300 of these procedures, right? But you don't want the surgeon who's only maybe done 1 or 2. Let's just put that out there, right? Ask your surgeon, how many of these procedures have you done? What have your outcomes been, right? A surgeon who has good outcomes, they're going to want to talk to you about their good outcomes. They're going to want to tell you about how person XYZ wasn't able to use a prosthesis for 3 years and now they're walking completely independently, right? They're going to want to talk to you about these outcomes, okay? Can you talk to some of their patients, right?
Yeah.
We have 2 beautiful examples that have been here with us this evening, and they're going to be coming on the show. Guys, you want to talk to someone who's been there, done that. As a clinician, I cannot ever relate to someone who's had osseointegration as much as someone who's already had that procedure done, right? And their patient model, they're going to tell you the good, the bad, and the ugly about it. They're going to really give you that inside look on what you can expect to see if this is really the right thing for you, okay? The most important question for me, what is your support staff? Okay. That surgeon should be walking you day by day through their program. They should know their program step by step. They should know what day they're going to send you to physical therapy. They should know what day they're going to send you to that prosthetist to get fit for the socket while you're in the healing phases, right? They should have all of this information right off the top of their head. Okay. If they don't, that means they don't have that support staff. Okay. You want to make sure you're going to a surgeon, and if you're going through the Oprah system, they're going to set you up with that route. Okay. Making sure you have that comprehensive staff around you. Okay.
Yeah, because if I could just add into that, one
Yes.
of the questions that we're often asked is, I have a great relationship with my prosthetist, and if I go get the procedure done, am I going to have to go somewhere else for my prosthetic care?
Yes.
And that's not at all the case, right? We want to support that relationship. So what will occur is there'll be training and education for your prosthetist that would be, coordinated. The doctor would reach out, or you would reach out. Somebody would include or make us aware that that prosthetist needs to be trained. And they would typically be trained in between stage 1 and stage 2 surgery, right? So that they're well prepared and ready for your opportunity when you present after stage 2. And that also, if you happen to live in a remote area and you can't get back to have PT managed in a facility, in the hospital or something like that, we also provide we provide training and resources to a local therapist, and then plug them into a therapist that can mentor them, that has managed many patients. But to Kosie's point, the rehab is important, and it needs to be teamed up with the prosthetist and your therapist, PT, OT, support staff, and Integrum understands that. So we will chase you to make sure that piece is put in place so that you're successful.
And the thing is, guys, I actually had a conversation with a physical therapist 2 days ago who had reached out to me, and she mentioned, she goes, look, it looks like I'm going to start seeing some OI patients in my area. And we were chit-chatting about the protocols, and she herself is not an amputee specialist, but just by looking at the protocols, and she's a licensed physical therapist, guys. So we have that bank of knowledge from our training. Looking at these well-established protocols, she's going to be able to start seeing these patients and doing really well with them. Okay, so that's kind of it makes me excited to see that the physical therapy component is really going to be an integral part of these programs. Okay. So actually, I'm going to go ahead and announce our website winner. So the winner of our $50 gift card is, hang on, of course, my screen timed out. David Fink. All right. So congratulations, Dave. Actually, I think he just posted a comment right there. So you're the winner of our $50 gift card. So guys, those of you who are our winners this evening, we had Rhonda, Marianne, and David will be reaching out to you, getting your information so that we can send you your gift cards this evening. And I think we did a really good job, Kurt.
You did a
We
great
covered
job. I
a
went
lot.
for the ride.
Ooh, here we go. Here we go. Sorry. He says you talked about swimming. Don't you have to have a special knee? My genium isn't waterproof.
That's a great, yeah. So if you're going to swim, right, the Axer is not waterproof, right? So you're going to have a connector device, right? Possibly what you use for your short limb prosthesis as your swim connector. And then of course you would need a knee that is waterproof, right? So you would talk to your prosthetist just as you would any other time to communicate that if you are heading into the water.
Okay. And Glenn is like, did Kurt already go? However, the Axer will release to help prevent a broken femur. Yes, he did. Nicely done, Glenn. Thank you for keeping us on track. Yes, he
Thanks,
did.
Glenn.
All right, guys. Holy cow. We covered a lot of information tonight. You guys were awesome. So first of all, thank you to my audience so much for being a part of this show tonight. Thank you for all the emails that you've been sending, the questions. Once again, guys, if you have any questions that we did not get to or any questions that might pop up after we close the show down, don't be shy. Send me an email. If I don't have the answer, I will hunt Kurt down and he will give you an answer. And a very, very big special thank you, Kurt, to yourself for coming on the show, being in the hot seat, and introducing me to Integrum. And Integrum, big thank you to the team watching this evening behind the scenes. Ian and Lindsay, thank you guys so much for all the support that you've provided and putting this show together. I am really looking forward to the other shows we're going to be doing this year. So just a sneak peek, guys, in May, we're going to have a physical therapist, one of my colleagues, coming on board to talk more in depth about the rehab process that's involved with everything. And then we're also having special guest Susan coming on board. She's going to tell us her personal story through getting the Oprah implant system. And then later on in the year, we have 2 more special guests that are coming that are just phenomenal. So guys, stick around. I've done a lot of talking tonight, so I'm going to go take a break. But in the meantime, there are all the websites here, guys. We're going to send you an e-blast with all this information later on this week, and you can get all the information there. So, as always, thank you for letting us be a part of your lives this evening. We will see you next week. Same bat time, same bat channel.